The next is a live case from the University Hospital Bonn, Germany. I would like to invite Dr. Genereux, Dr. Grube as moderator, Dr. Wang, Dr. Erglis, Dr. Capodanno, Dr. Chan, Dr. Ge, Dr. Hyo-Soo, Dr. Santoso, Dr. Zambahari as discussant. Please come up to the stage.
Thank you.
I think this Germany team is ready. We are going to Bonn.
Can you hear us?
Good morning, Eberhard.
Good morning. No, good morning to
yes,
you. Good afternoon
we can hear
to
you
us.
Clearly.
Good morning.
Thank you very much. I really welcome you.
Yes, it's early in the morning.
To a wonderful session, hopefully, and we have a full room here. George and Nikos very anxious to see this. Maurice was supposed to moderate with me, but for some reason he didn't show up. He stayed in San Diego. Now with me is Phillipe Genereux, and we have a great panel here. For me, it's obviously a premiere to look from the outside to the inside. Good luck to both of you guys, and I know things will be going very well. And thanks for getting back to us here early in the morning.
Thank you so much, Eberhard, for your nice introduction and your greetings. Hello to everybody. It's a great pleasure for us to have the opportunity to do this live transmission to Seoul, and hopefully we can come up with a nice case and live up to your expectations. We are a little bit nervous because we don't have you on our side. You are the most experienced live operator we know, and especially in our team, it's always very important to have you here. But we try our best, and we know that your spirit is covering us. Also, you are quite a distance away. So let me just introduce the team. You mentioned already Nikos Werner to my right. I'm going to do this procedure together with him. In the back is Christoph Hammerstingl at the echo machine, and he's very important, of course, for this type of intervention, and especially for the whole mitral space. And there is also Stefan Weber to mention. He's our colleague from the anesthesiology department, because we're going to do this with intubation, with the general anesthesia, this patient with a mitral clip procedure. And in the back there is also Professor Schrickel and Phillipe Fuchs. They're going to assist us. Maybe Professor Schrickel, he's going to put hands on the patient later on. Depends whether we're going to have time or not, but I'm not going to tell you this right away. Maybe this will be the surprise for the last 15 minutes. So maybe if, with no further ado, we could show you the demographic data and the comorbidity data of the patient. Maybe we could have the a first slide. So we are talking about a female patient, and the patient was referred to us repetitively because of a recurrent secondary mitral regurgitation. Interestingly enough, this patient underwent an interventional annuloplasty with the mitral line system in 2013. Initially, we were able to place, by the way, 2 pledgets we're going to show you in a second. Initially, there was a very nice reduction of the mitral regurgitation to grade 1 to 2. But since 6 months, the patient is coming back again and again with progressive dyspnea, New York Heart Association 3 to 4, highly symptomatic. And on the echocardiography screen, we saw evidence of a mitral regurgitation recurrence. So the past medical history is not too spectacular. No coronary artery disease, no myocardial infarction in the history, no cabbage procedure, no previous PCI. Patient is suffering from more or less mild chronic obstructive lung disease. What is very important here is that the patient is suffering from severe renal dysfunction. Its actual creatinine clearance is 23 ml per minute. Atrial fibrillation is quite usual as comorbidity in this type of patient with severe mitral regurgitation. And that's about it. Maybe we can have the next slide, please. Patient has no diabetes. She's suffering, or she used to suffer from hypertension, probably one very important cause for a heart failure situation. Hyperlipidemia is also present, and she's a former smoker, which is not too important right now, age 78 years and female, as I said before, and severe heart failure symptoms as key clinical presentation symptom. Next slide, please. And maybe now I can hand over to Christoph. He's going to explain everything else to you from the echocardiography perspective. Please, Christoph, go ahead.
Yes, thank you. Hello to everybody from my side. These are just 2 pictures. On the left-hand side, you see a 3D on fascia of the mitral valve, and the arrows are pointing to the 2 pair of pledgets who are placed in the mitral annulus for the partial annuloplasty, which worked out very fine during the first 2 years after implantation. And on the right-hand side, you see a 4-chamber view of the left ventricle, and you can appreciate that the left ventricular function is moderately reduced, which leads to a restrictive movement of both leaflets, but prominently of the posterior mitral valve leaflet, and you can see that the patient is suffering from functional mitral valve regurgitation, which we staged to be a moderate mitral valve regurgitation. And since the symptomatic, she's still highly symptomatic with New York heart failure, stage 3 to 4, and she's coming back every 3 or 4 weeks in our clinic. We decided that this mitral regurg needs to be treated.
Christoph, just a very brief question. Can you go back to this? And George, you know, we would like to, because the mitral clip is not approved in Korea yet, and I'm not sure whether many people know exactly what you're looking at. Particularly, what's interesting here is that the patient did have a previous procedure, which is the mitral line procedure, and the mitral line procedure is indirect or annuloplasty that has been done in 2013, and apparently this is a recurrency. And the pledgets that Christoph just showed, where the arrows are those pledgets that are placed with a catheter and then cinched. So he's looking at the 3-dimensional echo and shows this very beautifully. On the middle picture, on the right picture, Christoph, there is a moving structure. Would you tell us what exactly that is? What do you think that is? At the middle part of the left part of the TE.
The right atrium.
At the right atrium.
Yeah,
that's a plica, right?
This is only a plica. This is no real pathology. This is only. It's not an artifact, but is that we.
It's an additional plica in the right atrium. Maybe we can show you this live in a second. As you know, the mitral line procedure comes from the left ventricle, so the septum, the intra-atrial septum, hasn't been touched before.
Yes.
And maybe one additional note, just Christoph mentioned that if you look at the pledgets, you have one pledget at P3, which is here on the left side, and the other one at P1, which is here on the right side. And maybe you can appreciate that the pledget on the left side is still very close to each other. Usually they have a distance between 14 and 17 millimeters, and you can cinch them to 7, 8, or 9 millimeters, so roughly by 50%. But if you look on the right-hand side, the pledgets are not very close to each other. So the cinching process was probably overcome, and this may be one reason why we have this relapse, this recurrence of mitral regurgitation.
Yeah, very interesting.
And just let me add one additional point. It seems to be a very dynamic, as we usually see, a very dynamic situation with the functional MR. If you look at the live pictures, the mitral regurgitation is far more severe right now. Because when I looked at this picture initially, I thought maybe we shouldn't do anything because PISA and arrow seems to be not too large, and the vena contracta, as already pointed out by Christoph. But once we go live, you will see and you will appreciate that there is the higher severity to the mitral regurgitation.
George, Phillipe Genereux, who is with me here, and you know him, he has a question. Phillipe?
So, welcome, and thank you for this great case, showing this great case. So, are you surprised about this evolution, and what was the result at the end in 2013 of the MR and the EF evolution, the ejection fraction? First, are you surprised about this evolution? Is that standard for this device? Because just for sake of discussion, people don't have a lot of experience with that. And second, actually, what was the EF evolution since 2013? Do you have a collapse of the EF? Do you have a dilation of the EF, of the LV? So what was the evolution?
So generally speaking, I think it is to be expected that if you tackle the annulus, you may have recurrence of mitral regurgitation, especially in the situation of functional MR and severely impaired left ventricular function. This is true for this type of devices, which are more or less experimental. We did this in the frame of a study. But this is also true for the surgical approach. If you look at the data with functional MR after surgical annuloplasty, you're going to end up with a recurrence of mitral regurgitation in the 20 to 30% range within the next 5 years. So, and that's what we are facing here right now. To your second question, to be honest with you, I'm not sure completely about the evolution of the ejection fraction in this patient. I think the ejection fraction, maybe Christoph, you can correct me or comment on this, the ejection fraction was more or less stable in this patient. Maybe we have some further dilation of the annulus. Maybe you can comment on this because I don't know it from the top of my head.
Yes, I followed her up very closely during the last years, and in fact the ejection fraction remained stable. Might have been slightly improved after the first procedure, but in concordance with clinical worsening, it got worse during the last 6 months, and in line with the left ventricular dilatation. So I'm not sure if the recurrence of MR was the reason for the dilatation of the left ventricle or vice versa, but there is a simultaneously decrease of left ventricular ejection fraction and worsening of left ventricular dilatation during the last 6 months.
So that's what we usually see in this type of patient, progress of heart failure over time, leading to additional annular dilatation and then recurrence of the mitral regurgitation. So that is not specific to this type of technique, but I would say it's specific to all annuloplasty approaches right now.
Okay,
thank you.
Perfect.
So maybe we can show you what we have done already, or are there any further questions?
No, you can move ahead. Thank you, guys.
Okay, so maybe Nikos can guide you through what we have done so far, which is not a lot, but it's very crucial. Maybe he can show you together with Christoph about the septal puncture and everything.
Maybe we start with, we have a venous access. You can see here already, and from this venous access, we went to the right atrium, and on the echo you can now see on the taped video the transeptal puncture. You can see the tenting. What we aim is that we aim at a posterior position that was seen in the previous picture. You can see at about 5 o'clock, you can see the aortic valve, which is and the septum, the anterior septum, and we are very posterior, which you can appreciate in the picture at the moment. And next, the next important step is that we are not only posterior, but we also need a distance to the mitral, distinct distance to the mitral valve. You can see here we measured 5.7 centimeters, which is a little bit too large. The next one was 3.5 centimeters, and here you can see, next please, you can see the final size or measurement, 4.3 or 5 centimeters. From the tenting to the mitral valve. This is very important so that you have enough room to work with the clip. You can nicely appreciate the tenting, and in the next echo you can probably see how we punctured the septum.
So there's a lot of motion in the...
Here you can see how we go through the septum. It's in the septum, yes.
It's a very
floppy septum. And we, after puncture, we again measured the distance to the valve, and we were quite happy with 4.5 centimeters. And then we advanced the large E-valve sheath, mitral clip sheath, you can see now on the table, and that's the situation where we are at the moment.
So this is very, very crucial. If you are not posterior enough with your puncture, you're gonna have a aortic hugger. You're not gonna get around the aorta, especially if the aorta is a little bit dilated. Then you're gonna have issues with your whole procedure. And if you are too close, you're not gonna be able to pull on the leaflets with a clip. And if you are too far away, you're not going to be able to enter the left ventricle from the left atrium. So you have to be in a sweet spot. This is extremely important, and we always take a lot of time to find the right puncture site, because that eases the whole procedure afterwards.
Yeah.
So maybe we oh, please go ahead if you. Otherwise, we just proceed. This is the clip. We probably gonna have a two-clip situation procedure, but we don't know yet. We're gonna just start with the first one. We have to insert it into the sheath, which is in place, which is in the left atrium. Maybe we can have a echo picture and also a fluoro picture at the same time, if possible. So now we're going to advance the mitral clip through the sheath into the left atrium. It's easily to appreciate here on the fluoro screen. It's kind of convenient right now because we have already a landing zone, because we have this pledgets on the P1 side, which is on top, and on the P3 side, which is below.
Yeah, so George, just so that you know, we have a little bit of a delay in the comments. So there's a little delay due to the distance, I suppose. And the markers that you can see at the mitral ring are those pledgets that George was talking about from the procedure in 2013. So this is kind of a nice landmark. And we will see how he proceeds with the clip now.
How about the use of
so now we have to
position
the.
How about the use of three-dimensional TE to help guide?
Could you please repeat your question?
Device? to the mitral valve.
There was a question, George,
Yes,
about three-dimensional echo.
Yes, we can. Yes, yes, that's a very good question, and we use that a lot to guide us around in the left atrium. Over time, you can do that also only with fluoro. You get used to this. You know where you are moving in the left atrium, but absolutely well taken. 3D echo is key for this procedure, and maybe Christoph, you can comment on the next images.
Yes, now the essential point where we have to look on the direction the clip arms are opening toward the opening of the mitral valve, and we have to be with the clip arms perpendicular to the anterior leaflet, which is here, because here the aortic valve, so it's not a typical surgical view. And here the posterior mitral valve leaflet, you can see the platelets here on this side, and on the other side there's some.
Very nice.
Here you can see both platelets, and the clip arm should be, how I say, perpendicular to the opening of the mitral valve, so that we can have a good grasp of both leaflets when we dive down into the valve and make a pullback of the clip.
So, George, when you look at the and Christoph, when you look at the clip,
at the sheath.
and you said this is a potential case for two clips, are you placing the first clip purposely a little bit different, or you just try to catch everything with one clip and then look for the results?
Yeah, that's also a very good question. We will show you the jet in a second. Maybe let's just look at the orientation for 1 minute. I'll get back to your question in a moment. I think orientation seems to be okay, a little bit counterclockwise.
Yeah.
Like this?
Yes.
Okay. So, Eberhard, if you go back, Christoph, to 2D, and maybe you can show us, in X-plane, you can show us the MR. We can discuss your point. How's blood pressure right now?
Blood pressure is 110/60.
Okay.
In adjusting
Maybe we
the
can increase
direction
it a
of
little
your
bit.
clip, why don't you use the to and fro movement in order to loosen the torque? Usually we push and pull. You just why don't you just rotate? Why do you just rotate the device, the delivery catheter?
Because I was pushing and pulling a little bit.
Yeah, correct.
Because there's a
That's
lot
my
of
question.
tension on the system, so it's easier it's a little bit easier to torque it, to turn it around if you go back and forth just a little bit. So maybe we can go in and explain, Christoph. So usually we would try to go just for one clip. We can try here, but my expectation would be that this jet is too large, and we're gonna need probably two clips, and therefore I would aim a little bit on the medial side with the first medial side of the jet with the first clip, and then would expect to place a second clip on the lateral side of this initially placed clip.
Okay.
And what will you
I have
be aiming
doubts
for?
that we will be able to cover this just in terms of reduction.
Yes.
Yeah, probably if we end up with a mitral regurgitation 1, I think we're going to be in a good situation. Right now, maybe can you show me again the sheath? Yes, we still have some space, and I can pull back the whole system a little bit. Okay, can we go back now to explain? And maybe we'll have a look at the orientation again.
So now you can see the clip now.
So this looks nice. Orientation is okay. Can we go back to explain?
So you can see this is
a little bit on the medial side. Maybe you can go.
It's a very meticulous planning on how to position the clip.
Yeah, that's fine.
Exactly. And you can see on the angiogram now the clip is open.
And we dived already in the left ventricle.
Yeah.
But I don't like this bending of the catheter right now. Maybe we can...
There's some tension in it, right, George?
Noch mal raus. Yes.
Yeah.
You can see by the bend of the catheter that there's some tension in the system, which he tries to take away.
Okay. Now it looks much nicer to me.
Yeah.
We don't have this bending anymore, and as I said, we're aiming a little bit on the probably on the medial side of the jet. Maybe Christoph, you can show us the jet again for a second, if possible. Yeah, we are right on the spot. Let's get the color off.
Now you're right in the middle of the jet.
Maybe
yes. But Teguh, he tries to then position it a little bit more medially.
Both leaflet
because it's a big jet.
Yeah.
I think it's also important
now
to
we
mention
have
that
both leaflets.
He carefully
on the
pulled the device back until the leaflet touched the clip, and then lower the gripper down to.
So maybe Christoph can show us the loop again. We grasped already both leaflets. Nikos put the grippers down initially and then closed the clip. You can see this here, and maybe Christoph, you can comment, or Nikos.
Yeah, I think you can appreciate how the leaflets are lying on the arms, and now the clip is nearly closed. This is the replay. Now you can see the leaflets on the arms, grippers go down, and now the clip is closed.
So first is to really assure that we have a nice grasping of both leaflets in order to avoid a partial leaflet detachment later on.
Yeah.
So this is extremely crucial, and Christoph, I think this...
It was a good grasp, I would say, because both leaflets are completely...
Yeah. So he always likes to wait until he shows us the color to put tension on us. He also does this during these live cases.
Oh. Looks good, I would say.
So maybe you can... So we have this sludge already, this
a bit of lateral jet
in the left atrium. Yes, I would have expected a lateral jet, which would be here on the right side towards the LAA, but right now I see only a very small lateral jet and a small medial jet. But maybe, Christoph, you can guide us through your pictures and your images.
So this is an intercommissural view of the mitral valve leaflet, and you see here the lateral part where you can see the left atrial appendage, and here's the medial part. And the clip is in the center. It's normal that you see this movement of the mitral valve leaflet because you are not facing the leaflet part where the clip has attached both leaflets, and there's only a small amount of regurgitation, which could be due to the fact that the leaflet is still on the hook on the cheese, which might lead that the movement of the leaflet is a little bit restricted. But how you can see, if you put this into a perspective of the whole ventricle, this is only a trace of MR.
Yeah,
left.
this is
It looks good though.
less than one.
Yeah.
Maybe you can scroll around a little bit and towards the LVOT view, that we don't miss anything. And again, blood pressure is somewhere around 120. So this is very important, that you do not unmask a significant MR just by decreasing the blood pressure during the general anesthesia to 80 or 90. But this is not the case here. Don't use dobutamine during such a procedure, because dobutamine can also reduce mitral regurgitation and can fool you. So this is only a trace. I'm sorry, because I was expecting that we have to use 2 clips, but obviously we will not be able to improve this result by a second clip. But another very important issue is that we have to look at the gradient. You can see them elysing during the inflow, but Christoph probably is going to measure the gradient over the mitral valve in a second.
If the pulmonary venous flow is normalized,
Nikos,
I
would
think
you
we
go
can accept this
for
result.
another clip?
I think it's a great result. I think we have nearly completely reduced the MR. We have to carefully look for the gradient, but this looks very nice.
So this is actually what we said. You can plan on a second clip, but the beauty here is, he placed the clip at best as he could imagine right now, and you can test it. And it looks like this first placement was actually very good, with not much remaining mitral insufficiency, as you can see here. At any point in time, he can loosen up the clip yet and correct it. But if it's not necessary, then obviously, it's better for the procedure and for the patient. Kind of a surprising result that was reduced with 1 clip, don't you think?
Yes, absolutely. We were really planning for 2 clips, and if the camera could show you that we already prepared a second clip, because we were sure that we wouldn't be able to do it with 1 clip. But that's the best situation we can achieve right now.
And can you tell us what you do now, Nikos?
Maybe we can show you the.
Yes.
Yes. We are checking now that the clip is secure in the position where it is at the moment. We tried to reopen it with the lock in place. The clip didn't open again. So we are very sure that the clip stays there when we go for the further steps. Now we are starting to get the clip off the system, the delivery system. We pull the first line.
The locking line.
The locking line, which is gone now. Next step is a safety procedure to see whether the clip opens again.
Yeah, if you look at the fluoro, you can assure that the clip still stays closed.
So, and now we are in the position to get off the clip.
Maybe you can go to fluoro, to the
frontal picture.
Okay.
Yeah.
So now the clip is almost gone.
We have it on a security line now.
So
it's still on a security line, which I now take off.
The clip is in between the 2 pledges.
The clip is free now.
Now it's time to recheck. Sometimes we do have some recurrence of MR, and then we have to replan our procedure. There is some MR left, as we have seen before. Maybe, Christoph, you can comment on this?
Yes. You can never say how it develops after you set the clip free, but I would say there's some MR, but it's still mild.
It's very mild. If you look at the vena contracta, we have to measure that later on.
Yeah, you can't even see a vena
I think
contracta.
this is not significant at all. Yeah. So I would leave it with this. If you don't have any further questions, I would like to discuss another very important issue with you in this patient.
Yes,
and
any
like
questions from the...
Fill the extra
George,
the time we have
just
left.
Just 1 second, and I'm asking the panel if there's any question from the panel.
No, I just want to make 2 comments.
Please.
First of all, that in the Everest 2, this result is very, very good and more than acceptable, because they also accepted in the definition of acute procedural success moderate MR. So this is mild to moderate, so it's absolutely a good result. The second point is that I'm surprised of your surprise, because you anticipated 2 clips. Of course, everything can happen. This was a large jet. But anyway, the jet was central. This was a functional MR, so most of these cases can be accomplished with the 1 clip. Of course, when you have a degenerative MR, this is another story. Then you end up with 2 or 3 clips, etc. But these are excellent operators, so I'm not surprised that they finally had with just 1 clip.
Okay, Junbo?
Yeah. Could you please address again the puncture, because the secret, this is I think the most important part. Last time we tried to do a case and we were not able to reach the valve because we punctured too low. We have to repuncture again. Could you please explain this again? And secondly, with this clip, like TAVI, for example, normally you have a mild regurgitation. Will this regurg becoming minor afterward by following up, or will it become severe?
George, did you get the question?
It will stay that way. I mean, we have the data from... I understood the question. Maybe I refer first to the second part of the question. It will stay that way, certainly. We have the data from the Everest trial, which you mentioned already, and the recurrency was 20% within the first year, but after that there was no recurrency at all. So we are pretty confident that this is going to stay that way. Einfach rausziehen. And to your first question, we just have to change sheath. I will tell you in a second. Your first question is a very crucial one. Puncture site is absolutely key. If you are not confident with your puncture site, do not proceed. Wait until you get the right puncture site, which is between 4 and 5 centimeters in distance, and which has to be very much on the posterior side of the left atrial septum. Sometimes, and this is what we also encounter, sometimes you cannot do that. We had a patient a few days ago in which we could not achieve this because the left atrial was, strange enough, was too small, and we were not able to place the sheath at the right positioning, and then we stopped with the procedure because we did not feel that we could end up with a successful procedure. And in this case, you have to talk to the surgeon again and find a different solution.
So it's posterior. I mean, you have to have enough room to come from up down into the mitral valve. Any other question?
Yes,
Teguh,
I have 2 short questions. One is that I noticed that you have measured the mitral gradient. Diastolic gradient is less than 5, and that means that you don't create mitral stenosis. But we normally measure also the pulmonary, assess also the pulmonary venous flow. If the pulmonary venous flow is not blunted or not reversed and then normalizes, then we will accept that as a good result. That's question number 1. And question number 2, what is the place of Carillon device in this particular case? Because this is a case with functional MR. And you have already placed a pledget there, mitral line.
Yeah, maybe to your first question, we do not usually use flow in the pulmonary vein or pressure in the pulmonary vein. Christoph, maybe you can comment on this question?
Yes, that's due to two facts, because first, it has been introduced in the Everest trial that you should not accept a mean pressure gradient more than 5, and this has been confirmed by independently because this was only criteria which has been designed during a study, but it could be confirmed independently in a larger series of patients. But to our experience, it's only the mean gradient which is predictive for future development of severe mitral stenosis, because those patients on the table under general anesthesia, there are a lot of issues that you can debate about, and to our experience in this situation, when the patient was fasting for 24 hours, the pulmonary venous flow is not so, we are not so confident to measure only the pulmonary venous flow.
And maybe shortly to your second question, because we would like to show you something differently in a second. Carillion device or other annuloplasty devices. Carillion is an indirect annuloplasty device, and Christoph and Nikos do these procedures together here in our hospital. I don't have personal experience with that. There are a few studies out there, and as far as I gathered, Christoph and Nikos, maybe you can correct me, it is a procedure which is not as effective as other procedures which we have in our hands right now, but for patients which we cannot treat with a clip or which we cannot treat with a cardioband. I think that's the most potent annuloplasty device we have right now. Then we can use the Carillion device with some success.
So for the audience,
maybe,
George is just commenting on the Carillion device, which is a device that is placed in the sinus and gets the sinus. It's the indirect annuloplasty approach. And Christoph has some experience together with Nikos. They're doing a little bit of a trial there, of a study there, placing that. The beauty of Carillion is it's fast and it's not very dangerous. But obviously, as George said, it's probably not very, very effective. It can be an additional procedure to something that has been done before. Andrejs, do you any question from your side over there?
Yeah.
Well, I guess it was really brilliant procedure, and I'm happy that it was so good with one clip, and then we not the second one. But in my question would be, but actually you answer the question of a Carillion device, and then we're also working on bit other with shortening annulus, and I guess that it could be maybe. Do you think that it will be also a future for a combination for those two different actually types of devices?
Oh, yeah. Very good point. Very good point. Yes, I think there is a space for this. If you have a dilated annulus, and then you still have a degenerative part of the valve disease, then it is a nice situation where you could use an annuloplasty device on one hand, as I pointed out, cardioband, for example, and then maybe you can use a clip in addition to manage a partial flail or so. But maybe we can discuss in a second, but we would like to show you something differently in this patient. As I pointed out already, the patient has severe renal insufficiency. The creatinine clearance, or the GFR, if you will, is between 20 and 25 ml per minute. And he has a severely increased Jet-Swiss score, so a severely increased stroke risk due to his atrial fibrillation. And we do not have an option for oral anticoagulation in this type of patient, which has been shown nicely in studies. Novel oral anticoagulants are no-goes because creatinine clearance is too low, and Macuma or vitamin K antagonists are also not safe and are even not admitted in Germany in this type of patients, although we treat this patient with this type of medication. And therefore we notioned, due to the high stroke risk and due to the high bleeding risk on the other side, we may add, while we are here still in the left atrium, a left atrial appendage closure, in order to reduce the stroke risk in this patient. And while we were discussing this, we changed already the sheath. Nikos is still by my side, and also Professor Schrickel, Jan Schrickel on the other side, and maybe we can go to fluoro. We just placed a different sheath. This is a Watchman sheath, a 13 French sheath. Is it 13 or 14 French? It's
so
14
what he's
French,
trying to tell you is that
with the guidance of...
While he was talking, they were exchanging the sheath, and they're adding a procedure now apart from the clip. And that was Phillipe's question, how are they dealing with this? And that's what George is just explaining. Always good for a surprise.
So thank you for translating, Eberhard. So we try not to use contrast dye or just a little tiny bit of contrast dye. And if you go to the echo, you can see that the guide is already within the left atrium. Christoph, maybe
yes. You can see it come in here. You see the transeptal, and you can follow the guide on its way into the left atrial appendage, and you see that's what we want to reach for the Watchman device, that we have a certain depth in the LAA, and you see that the guide is pointing right to the...
So far we haven't looked at it with contrast dye. We measured it just with the TOE, and the diameter were 21 by 24, and therefore we prepared a 27 millimeter device. The device is here loaded already. I hope you can see this.
Yep.
This is a Watchman device, a Watchman occluder, and we're going to insert it into the sheath. You have to be very careful not to produce any air bubbles, any air emboli. Therefore, you have to rinse during the procedure and leave the guide as low as possible in relation to the heart in order to assure backflow. Then you have to adjust the system to the sheath, and maybe you can go to fluoro and echo at the same time for the audience. I hope you can see this.
Yeah, we see this very well.
Eberhard, is that visible?
Yes.
And now I think we are as I said, we haven't used contrast dye as we usually would do. I'm just going to place it by echocardiography guidance. And as you can see here, maybe I cine it, I'm going to release the device in the left atrium.
There you go.
And now maybe I cine it again. Now the Watchman device is already in place, and we don't need fluoro right now. We have to ask Christoph what he thinks about it.
Looks great on echo.
There are several issues we have to discuss. First, is it stable in the LAA? You see that it's behind the circumflex, which you can see here. And this is what we want to reach, positioning in the LAA, which is behind the circumflex artery, which has been identified that this is a good predictor for stable positioning. Then we can measure the compression on the device.
So it's a 27 millimeter device, and you would like to have compression of about 20%.
Could you please put
So
a
I measure here 21 millimeters.
Residual fluid there?
Absolutely,
Sure.
that's what we would do the next. So you can first see if it's played stable in the LAA, and then we look if there are any leaks left, which might increase the risk for thrombus formation. And so
I think it's nicely seated there. I don't see any leakage, but this is very important to check. I mean, what I'm always afraid of is of embolization of the device. But this seems to be very nicely seated in the left atrium. What we have to do is a tuck test. Maybe you can look at the fluoro. I do a thinner.
The tuck test is also negative.
And there you can see
Very
that we
stable.
can nicely pull on the device.
Depends how strong are you.
Yeah.
You can always pull it out. I mean, if you just have to pull hard enough.
But basically the tuck test is more to make sure
But
that...
I think, Christoph, are you okay?
Yes.
Pardon me, Eberhard?
Yeah, looks very nice.
Okay, so
Now he's detaching it. Came off.
We just released the...
We know from the PROTECT trial that the
So now the
result
system is free, and maybe Christoph,
the result of Watchman trial.
you can check it again for us.
You have to talk, Teguh. Otherwise, you have to talk because of the delay. Just keep talking.
The results of Watchman trial. Watchman is superior as compared to warfarin. Long-term follow-up until 4 years in terms of reduction of combined endpoints, stroke, cardiovascular death, and total MACE, and also cardiac mortality also. And besides, the patient is an elderly patient and has kidney function, so we will have a problem if we put the patient on long-term anticoagulation therapy. So this is a very nice strategy.
That's the rationale. Yeah, why we did that. Maybe you can have a look at the 3D echo again. There you can see the device in place, the left atrial appendage closure. And at the same time, if you swing it around a little bit, you can see the clip and also the pledgets. And this is it. We closed already the groin. If you can sweep to the groin for a second, patient is completely off any sheath and is ready to get off the table.
Yeah. So now he closed already with the famous V stitch. As you can see, he was tying a knot. Can you explain that, George?
Is this figure of 8?
I'm not sure. I'm not sure. Yeah, that's a figure of 8. You have to put it proximal and distal to the puncture site, and then you just have to close it. It looks a little bit like a German sausage, like the end of the German sausage, but it's quite effective, and you can loosen it up
after 12 hours.
After 12 hours, and we use that also for our electrophysiology interventions. It seems it's very useful, and it's very cheap at the same time.
Great. So, are there any questions from the panel to the team there?
Dr. Christoph, excellent result, congratulations. I'm Jason from Hong Kong. So just one technical point I want to raise. So to my knowledge, the transeptal site for LA culture for the Watchman and for the mitral clip usually have different criteria. So in your case, so you use the same puncture site as for the mitral clip for the LAA culture, or you puncture the second one?
No, we use the same site, but a very good point you raised. Sometimes it can be difficult to use the same puncture site because it can be very tricky to get anterior-wise into the left atrium. That's why we tend to puncture as low as possible in order to have a large flexibility within the left atrium. You're absolutely right. But I think in this patient it is not so crucial for 2 points. First of all, the septum is very floppy and very forgiving, so you can even negotiate the septum with the guide a little bit back and forth without injuring it. And second is, this is a large atrium. So you have lots of freedom within the atrium to negotiate and navigate your wires and your guides into the left atrium.
Yes.
But a well taken point, absolutely.
Yeah, thank you.
Any other? Because we're coming close to an end, we wanted to thank all of you for a wonderful procedure, very successful procedure. 2 procedures for the price of 1, that's good. And, great results. And the team, from my side, I wish I could be there, but it was very, very nice, very well demonstrated. All the best from Korea for a successful procedure, for a great case. And thank you very much to all of you. Thank you.
Thank you so much for having us. Thank you. Have a nice day.
Okay, thank you very much.